Thank you very much. So I'm excited to be kicking off our talks looking at extraintestinal manifestations of IBD. I will tell you, besides these disclosures, I am not a rheumatologist, but I do talk to them. So we'll see how this goes. So, I hope in the 15 minutes that I have that we can at least start talking a little bit about the epidemiology of EIMs and focusing, at least for my talk, on the rheumatologic issues that face pediatric IBD patients. And then I'm kind of a simplistic person, so as I was going through putting this talk together, I wanted to start sort of classifying how we should approach rheumatologic issues in IBD, and I hope this kind of helps us organize things as we look at our patients. We'll talk a little bit about the etiopathogenesis. I actually have to have at least one slide on the microbiome and immunology, so this is my one chance. And then I am going to end by delineating some clinical approaches, both from a diagnostic standpoint and thinking of your differential diagnosis, and how we should look at therapeutic interventions as we partner with our rheumatology colleagues. And so just a brief sort of overview on extraintestinal manifestations, since this is what the session will be about. So as we all know, EIMs are common in both children and adults who live with IBD, and depending on the studies that have been done here in the US and in Europe, up to 50% of at least adults will have at least some form of an EIM. And it appears that with children, you have similar or even greater numbers. And the primary systems that are affected are going to be the joints, skin, hepatobiliary tract, and the eyes. EIMs, we know, can often parallel the GI tract inflammation or disease activity. It's more common in Crohn's versus UC, although you see it in both. It can often precede onset of GI tract symptoms and is often associated with more moderate to severe disease. And so this was a nice study that came from the Swiss IBD cohort, and they looked at over 1,200 patients and found that almost 30% had greater than or equal to one EIM. And what you can see on this diagram is that about a quarter of the patients had up to 4 EIMs before the IBD itself was diagnosed. So certainly something that we all need to think about. And for the remaining patients who had EIMs, it usually came after the diagnosis itself. And again, the EIMs that were predominantly reported were rheumatologic in nature, especially peripheral arthritis, as well as axial arthropathies. So when we talk about joint-related issues in IBD, I'm excited if I can say, oh, look, the knees, the elbows, they don't look normal. But I realize that we need to do a little bit of a better job than that. And so, again, musculoskeletal, most frequent EIMs, up to 50% of all IBD patients, similar in children. And recent studies have looked at this, and they'll say at least a third, if not more, will have at least some sort of joint issue at the time of diagnosis and certainly at follow-up. And that we should be thinking of all these when we look at our kids, and it's usually higher in females, patients with Crohn's, in the pediatric population, and those who've had longer disease duration. So before we go further, just want us to make sure that we're sort of defining the different symptoms and different issues that come with joint swelling, inflammation, and pain. So I think we often say, oh, there's a joint problem. It must be arthritis. At least maybe that's how I think. And so just talking through this a little bit. So when we say arthritis, we're actually referring to inflammation and or effusion within the joints, often manifested by pain and tenderness along with swelling and warmth at the respective joints. Whether you just think of arthritis or then you think of the spondyloarthropathies itself, which include both arthritis and enthesitis, which refers to the inflammation at the sites of actual insertion to the bone. So we're talking insertion to the bone with the tendons and ligaments. And again, you have both pain, tenderness, and some swelling. And then dactylitis. It's this flexor tenosynovitis with soft tissue swelling, and you can see the joints here. It's that diffuse swelling, what they almost call the sausage appearance or sausage-like joints, and it's often associated with psoriatic arthritis. And then finally, the term arthralgia, which is non-inflammatory joint pain. So you don't have any of those other manifestations that I just referred to, and no swelling or fusion. So when we first just think of peripheral arthropathies in children, not necessarily IBD associated, I think we often think of juvenile idiopathic arthritis, or JIA, versus the spondyloarthropathies. And so when you think of JIA, it's usually transient, migratory, and younger onset, so earlier in childhood, often associated with your autoimmune antibodies like ANA, anti-CCP, rheumatoid factor. And the type of arthritis that you get can involve both the large and small joints, often symmetric, which is a little different from what we're going to talk about with the spondyloarthropathies. It can be both posse or polyarticular, and often there's some form of systemic disease with this. So then when we talk about the spondyloarthropathies, it's chronic inflammatory process, usually onset a little bit later in childhood to adolescence. This is truly considered to be an EIM of IBD, often HLA-B27 positive, but not always. And this is where you have the arthritis with the enthesitis. So it can be both peripheral or axial. Often you just start off with a sacroiliitis or some sort of spine involvement, and often the lower extremities are affected. So this is just a nice little mini Venn diagram, and I kind of thought if you look at it, it kind of looks like Mickey Mouse, Disney, well, with multiple ears, a little bit of a mutated Mickey Mouse. I never got to go to Disney, so that may be my problem. But you can just sort of see the collection of the different SPAs or spondyloarthropathies that we're talking about, with certainly the focus on the enteropathic or IBD-associated arthritis. And so when you talk about peripheral arthritides associated with IBD, you've got two types, both the posse and the polyarticular. So when we talk about polyarticular, usually acute, self-limited, less than a couple months, HLA-B27 positive, often parallels the IBD GI disease activity, usually associated with other EIMs, although it's not an absolute, affects less than 5 joints, and it's asymmetric but often non-erosive. Versus the type 2 or polyarticular, where it could be chronic, HLA-B44 positive, often does not correlate with IBD GI tract activity. And the only EIM it's usually associated with, if there are other EIMs, will be uveitis, affects often greater than 5 joints, and can be either symmetric or asymmetric, and it may be erosive. And so the other type of arthritis we have to think of is the axial. So you can either have sacroiliitis, which is just isolated, and that refers to the inflammation of the SI joints that could be either uni or bilateral, usually asymptomatic, but when you do have symptoms, it manifests with pelvic pain and plus minus limited spinal mobility. And when you look at it radiologically on MR, you can often see erosions and sclerosis. Whereas ankylosing spondylitis will involve a lot of this things that you see with sacroiliitis, again, refers to the chronic inflammation of the axial skeleton, can have peripheral spondyloarthropathies associated, and there are clinical criteria. So you've got, this is where you do have more of the symptoms, low back pain / stiffness for greater than 3 months with limited lumbar spine mobility, and sometimes you could have restriction of chest expansion as well. And radiologically, you find sacroiliitis. So what are other rheumatologic issues? I always think of joints, but there are non-joint related issues, and I bring this up because certainly you will be involving your rheumatology colleagues should this be an issue. So some things to remember, some of the issues that I'm going to bring up, they're typically not correlated to IBD disease activity. So one is orbital myositis, where you get acute eye pain, diplopia, eyelid swelling, and on MR what you find is a diffuse enlargement of the extraocular eye muscles. You've got the gastrocnemius myalgia syndrome, manifested by having pain in the calf, diagnosed by muscle biopsy, and then polymyositis, again, a lot more rare, but certainly things that you need to think of. You can get increased weakness with myalgias, often have an elevated CPK and confirmed by muscle biopsy. So this is just a summary, again, looking at your axial peripheral spondyloarthropathies and remembering that IBD can be part of it as you look at the different criteria. So I told you I have to have at least one basic science microbiome slide. So, when we talk about how does this happen, how is this associated, joints and GI tract, we know that the gut is the major organ to think about and everything else sort of revolves around it, but how does this happen? So the thought is that when you have someone who has IBD, we know that there could be the dysbiosis, breakdown of the mucosal barrier, And then you have certainly translocation, activation of your T cells that lead to increase of pro-inflammatory cytokines, not only what we classically think of when we think of inflammation, especially when we think of Th1-mediated cytokines like TNF, but also IL-23, which we've heard a lot of today, both in Dr. Sand's very nice overview. Dr. Busvaros brought up again, medications like ustekinumab. And so I just bring this up because we have to start thinking of all these issues when we think of the different biologics that we use to treat both IBD but also joint issues, especially if you have a patient who, even with Crohn's disease under reasonable control, still has issues with their joints that are not under complete control, because we really do need to start thinking not only of the anti-TNFs, but also the IL-12, 23 pathways as well in terms of inflammation. So whenever you start doing sort of the diagnosis, first there's always an extensive differential diagnoses, lots of abbreviations. I'm not going to read all of these through. I suspect these are all things that are going through your minds as someone comes in with arthralgias plus minus joint swelling. But again, in broad categories, you want to think of the orthopedic issues, other rheumatologic disorders, infections certainly, hematologic, and various pain syndromes, especially if you don't see anything grossly abnormal on physical exam. So diagnostically, what do? The first thing, obviously, is your physical examination. Look at the joints, look at mobility, and look for other stigmata, skin lesions. Laboratory data, there's no definitive testing, but certainly you're going to think of your autoimmune markers, especially if you're trying to differentiate between something like JIA versus an IBD-related arthropathy. HLA-B27 typing, certainly your inflammatory markers, CPK, especially if you're worried about a dermatomyositis, and then radiographic films, both plain and MR. So medications, I'm not here to tell you exactly how you need to do this, but things that we like to think about when we have a patient with rheumatologic issues associated with IBD, as we often see when we work with our rheumatology colleagues, especially for milder cases, they may recommend the NSAIDs like your COX-2 inhibitors and physiotherapy. Clearly, as GI docs, we worry about the impact that these medications will have on gut symptoms, inflammation, and permeability. So I know that none of us are huge fans of using these long term. Certainly, with someone who has more moderate disease, you're going to move to your DMARDs like your sulfasalazine, methotrexate, and azathioprine. Corticosteroids sometimes are necessary, especially when you need to get a significant inflammation under better control. Certainly there's also not just oral steroids or even IV, but injectable steroids as well for individual joints. And then finally, the different biologic agents. But the bottom line, though, is if you're at a point when you have a patient who is having issues with joint symptoms that are not responding, we're going to be partnering with our rheumatology colleagues. And so, just to tie up my talk, and this is my last slide, just some things I want you all to think of. A, identify the patients who you know have poor prognostic factors. So do they already have radiographic damage to the joints? Do they have high disease burden or activity, so persistently elevated inflammatory markers, or high either physician and or patient global disease activity indices from a rheumatologic standpoint? Is there axial involvement, and do they have the peripheral arthritis with enthesitis that is not responding to the typical GI treatments for their IBD? The rheumatologists always tell us, especially if it's an EIM, optimize your IBD disease control, and we have to remember that. But ultimately, as we try to differentiate between those that are directly related to IBD activity versus independent of GI disease, I really have to advocate early referral to rheumatology, especially if you have someone who you are comfortable that you have diagnosed their GI disease, that you have them on a reasonable path, and the disease activity is still fairly active. We really want to partner with our rheumatology colleagues early on. Certainly, we don't want our patients to get to the point where they have erosive changes. And secondly, often when you talk to patients, it's not just about treating a SED rate, but also the impact it has on the quality of life. So I hope that this overview was at least somewhat helpful as you start thinking of rheumatologic disorders and IBD. So thank you for your time.